have a little fireside chat for you here. We've got some great speakers. So I'm going to let them introduce themselves, but just briefly, I have Bob, Amy, and Abhinav. So Bob, you want to do a brief intro?
Sure. I'm Bob Wachter. My day job is I am chair of the Department of Medicine at the University of California, San Francisco, so a very large academic medical center here in town. I tell people I'm what happens when a political science major becomes an academic physician, so I think about the system, and that has led me to think a lot about technology, and I have a new book that there's available to all of you, I think, called A Giant Leap. There we go.
Right
Thank
here.
you so much.
Look outside.
It's actually not out for a week, so you are the first ones on your block to get the book. This is about sort of what is actually happening with AI meets healthcare and what's good about it, what's scary about it, and where it's all going. It took me about 2 years to research it, and I'm actually quite proud of it.
Yeah, awesome. And Amy, we've worked together for some time.
Yes, hi, I'm Amy Gleason. I'm the administrator of the U.S. DOGE service, which works to modernize technology across all the federal government. And then I spend a lot of time also working with HHS as a senior advisor there for technology for Dr. Oz.
Yeah, and of course you know Abhinav. Abhinav's role here is to provide color commentary about what Innovaccer is actually doing on this front. So what are we doing here? What's the idea here? We've been talking about autonomous healthcare, bringing in automation, bringing in technology that works in the background throughout the entire conference. And as you can see here, Amy is representing that federal level push to really reduce administrative waste in healthcare and tackle some of the really pervasive problems we've been focused on together in different ways across different roles and companies for some time, really unlocking interoperability, driving data exchange forward, but also using that to bring technology that patients actually want and need, and finding ways to leverage the federal government's huge power in that space that has been kind of left to the side for a long time. And then Bob did say it was okay if I called him Bob, Dr. Wachter, is bringing that really frontline clinical AI lens, and obviously has just completed this multi-year research project on what's actually happening in those health systems, in the delivery system, at the point of care as well. And so we want to kind of move from the policy lens we were talking about before solely, and the infrastructure, how we can actually do this, and then really talk about into the clinical reality, into the reality at the point of care, frontline, and what does that AI transformation look like in those stages. So I think that's just really important framing here. Let's start and get a little bit of the background. I think it's important for us to take a moment and step back. I think in particular for you, Amy, you've been doing this for some time. Talk about before DC, although we know you're DC, Nashville, back and forth whenever the moment will allow you. Also just note, Amy did get in at 3 a.m. last night because of the massively delayed flight. So please, amazing dedication, truly. It was very challenging to get here. Before DC, before CMS, before USDS, you were really experiencing healthcare both as a technologist and also as a caregiver. Can you talk about your personal background that really led you to say, hey, the problem isn't just the technology, which you worked on, you know how to build it, you know how to implement it, but also just the broader system?
Yeah, so I started my career in nursing in the emergency room, where I first saw how dangerous it was when a provider didn't have the information that they need, and just how unrealistic it is that we ask patients to remember their whole medical history, all their medications, any critical information while they're scared or in pain and not in the best moment of their life. And so that quickly led me into technology, where I saw the promise that tools could give providers the data they needed in the moment that they had it and could help deliver better care. So I worked in electronic medical records for a while and did a lot of technology through practice management and supply chain and leading into HIEs. And then my daughter was diagnosed with a rare disease in 2010, and she was then an 11-year-old girl who was a cheerleader, very active gymnast, could flip and twist all over the place. We called her the Energizer Bunny because she never stopped moving. But she started having all these weird symptoms that seemed pretty typical, not that unusual. She had rashes that started on her elbows and her knees, but she was a gymnast and hit the mat a lot. That wasn't that weird. She broke several bones, but again, she was a gymnast. Some of those were doing tumbling, but it started to where she just barely hit her elbow and she broke the end of her elbow off. She was just walking down the street and broke her foot just walking. And so these all kind of seem weird. But then she started losing all of her tumbling, and I'd pick her up at gymnastics, and she was sleeping. She started having stomach aches and headaches, and eventually she couldn't stand up off the floor or walk up the stairs. And she accidentally got diagnosed with this rare disease by a skin biopsy that the dermatologist ran. And they found out that she has juvenile dermatomyositis, which is a systemic vascular disease. But it took a year and 3 months and her to not be able to walk before she got diagnosed, even though she was seeing world-class doctors across great health systems and great provider practices, but no one could see her information all in one place. It was all siloed, and they were all seeing it from their perspective of the care. And so that was really when I realized how broken the system is, from a mom carrying a mom binder from doctor to doctor to doctor, and how hard it is to be a patient and to try to say, no, I just had that, or this doctor told me this, and you're saying something different, and try to be that glue between the whole healthcare system. And that was with me with a nursing background. I can't imagine how hard it is for other people. So that's really what drove me to the passion I have to finally fix this interoperability problem and to give patients better tools to be able to manage their health and to be able to have a better experience.
Yeah, and then talk briefly about recent experience around tackling some of these big administrative problems at the federal level. You know, what problems are so big that, you know, you and your colleagues at HHS and CMS and in the White House are saying, we've got to try and do something different this time?
And so I will say I was disappointed because I was at the White House 2018 to 2021 and worked on interoperability at CMS. Some of this is probably sounding familiar. And I helped write a rule in 2020 that was the provider access rule to help providers get access to claims data. And its effective date isn't until January 1st, 2027. So I came back in 2025, and the thing I did 5 years before wasn't even live yet. So that was pretty frustrating to me to see how slowly things move. So we decided to take a step back and try something different. That regulation, we've been trying it for 20 years. It just hasn't really made the difference that we would like. So things should work on paper, but it's really just hard to get it to work all the time for all the people. So we decided to use the power of convening the government to try to get this to change in a fast way. So we set goals for 6 months and 12 months instead of years, like we've usually had. And that kind of had two tracks. One is on interoperability. We believe, especially with AI, that you can't make things work if you don't have the data underneath. The models are only as good as the data they get fed. And we also think that patients still have such a hard time to get their data that we can't unlock innovation for patients directly without giving them access to their data. So we created this interoperability framework, and we asked people to come and join us to do that. Innovaccer is one of the brave companies that stepped forward and said they would do it in this fast time frame. And then on the other side, we created 3 patient use cases. One is Kill the Clipboard, where a patient could verify their identity one time using Clear or ID.me and validate they are who they say they are, so the health systems can trust that it's the patient asking for the data, and then get that information into an app of their choice, and then share that. We call it Kill the Clipboard because it can be a QR code or a smart health tap link, just like when you go to a concert or the airport. And then we also think it's important that patients get transparency into who's getting their data, kind of like your credit report. So that's the patient side of that. Once they have that data, we want them to be able to use conversational AI on top of that. And I have tons and tons of stories about how that's helped my daughter, Morgan, who's 27, but also my 84-year-old dad now. And so I hear stories from people across the country every day. And then the last piece is just diabetes and obesity, helping people get personalized recommendations for that. And as part of that, we decided that there were 2 things the government had to build ourselves, where all the rest of that is all in the private sector. And we are building a national provider directory. So there are over 5,000 provider directories, and every single company out there takes what starts at CMS, and then they clean that data and try to maintain it, and we're doing it over and over and every day. That's over a $6 billion estimated cost to the system a year. So we're taking that on and building one place that everyone can update their information. And that can be credentialing, licensing, interoperability data, what health plans are taken, all of that in one place. And then we are also adding modern identity to that provider directory for providers and to Medicare.gov for patients to start to drive this modern identity into the rest of the healthcare system.
That's amazing. So Bob, you can see that the federal government is trying to fill in some of those gaps and push in some of those areas, but you have spent the last couple of years really researching how is this actually showing up in the clinical setting, in academic medical centers, in provider systems. What's actually working right now, and after you tell us what you've learned briefly, then also tell us, how does the work that the federal government is doing in the front, how does it, help? What else can they do to really push forward the adoption here?
Well, first of all of that sounds fabulous. So thank you for doing that and remembering all of it after landing at 3 in the morning. Everything Amy said is something I endorse and I think makes the system better. There's a lot of friction in the system that's just craziness, and the provider directory is just a perfect example of it's a ridiculous system. You should clean it up. I mean, one of the things that strikes me about what's so exciting about this era and AI meets healthcare is I can tell you on November 29th, 2022, the day before ChatGPT came out, I didn't sit there and say, Uber stinks, I really need a driverless car. I took a Waymo over here. It's better, I like it better, but I didn't need it. I was certainly not on Google saying, this is an awful way of searching for information, we need something better than Google. In fact, I couldn't actually imagine anything better than Google. But I don't know anybody on November 29th, 2022 who said, the healthcare system's just perfect. We really don't, let's not muck around with it at all. It's fine for patients, it's fine for providers, doctors, nurses are all pretty happy doing their work. They're their best selves every day. I mean, the system is massively chaotic, and there's so much room to go up that at the end of the day, with my book, I came out of it very optimistic, in part because I think the system it needs these kinds of tools to be better. It's clear that our go-to solution over the last 100 years has been we need to do a thing, and therefore, and the existing workforce is not enough, and therefore we need more people. Not enough primary care docs, we need NPs, we need PAs. The billing thing has become more complex, we need more people in the billing department, we need prior auth writers, and then people stick the prior auths in fax machines.
Coding.
We can't do any of that anymore. We can't afford it, and we can't even find the people. So the time is right for these tools. The tools now are good enough to make a real difference. What is it doing in my own life? I had a piece in the New York Times last week where I started off saying, when I'm on the wards in the hospital, in many days I'm a generalist, I'm a hospitalist, and many days I've got questions that I sort of could use a subspecialist to help me with. And so what I hope for is what's called a curbside consult, which means I happen to run into my favorite infectious disease doctor in the cafeteria, can I run a case by you? And now I get 10 to 15 curbside consults in the morning, but I do it using AI rather than being dependent on the serendipity of running into my favorite colleague. So we're all using AI, whether it's using Gemini or GPT or Open Evidence or other tools like that. We're all using those tools to get better information, essentially subspecialty level information for generalists like me. Most of us are using an AI scribe. Most of us are using AI to summarize patients' chart. 1 out of 5 patients has a chart longer than Moby Dick. If you remember from elementary school, that's 600 pages. The idea that I'll be able to review it in 3 minutes is a joke.
And it's all the same information copy-pasted.
And it's all copy-pasted anyway. And the AI is drafting discharge summaries. To me, this is all really important, but it's training wheels. It's getting us familiar with and comfortable with using AI in a clinical setting. But those are singles. The real home run here is all decision support. Yeah. Whether it's decision support for a doctor or a nurse or a patient or a family member, it is now how do we, and I'm glad we didn't start too aggressively on decision support, because if you blow it and you kill somebody, it would set AI back many, many years. So you must start with easy wins like scribes, like chart summarization, stuff like that. But very soon, and I think we're going to get there, we have to get to a point where the AI is giving you information that helps you make a diagnosis, helps guide you to the best therapy, the most cost-effective therapy. And as the question for Amy, the EHR vendors have what feels like, maybe unfair is not the right word, because they got to this position by producing a product that we all own now, or we have, and they are producing AI tools, and by and large, at least the EHR vendor we have, the tools are good, and they're probably going to get better, and we're pretty sure the company's going to be in business 5 years from now, which we're not sure of with a startup. We are sure with Innovacer, but not for many startups. And so they have a real advantage, and it probably does slow down innovation. So I would be interested in how the government is approaching the issue of sort of the monopolization of the EHR as we move into the AI world.
Yeah.
Yes. So first of all, I will say that my daughter's pediatrician actually at one point said, please stop listing my name on her records as a provider because they just inundate me with all these paper records. She had stacks and stacks back in the day, so I related to that. I think what we really tried to do is use the power of convening in this administration. So we've done it with most favored nation drug pricing. We've done it with prior auth to get payers to say that they would reduce the number of prior authorizations needed. And then I'm doing it with this health tech ecosystem of really kind of putting a little pressure on everyone to say, you know, we all know this is possible. It's been possible. This is not a technology problem. This is a trust and a cultural change that we have to make. And so we had Apple, Google, Samsung, Microsoft, Amazon, OpenAI, Anthropic, Epic, Oracle, Meditech, Athena, eClinicalWorks. I mean, all of these major companies came into our pledge back in July when we had 60 companies, and now we have 600 companies that have pledged us. And I think the big thing is that we're basically saying this is your chance to be part of the solution. Everyone says that they don't want to be regulated to death. Everyone says people go off in small little committees and make decisions and then they weren't aware of it or they didn't have any insight into it. This is your chance where it is come one, come all, come big, come small. This is your chance to have an equal voice to those players that may have a monopoly or may have an advantage. A small, tiny startup has just as much of a voice as an Epic or an Oracle or a Meditech. And so I would encourage everyone in this room, if you have not already, to go to the CMS Health Tech Ecosystem Pledge site on CMS. Take the pledge. You could add it into a Slack channel, which if you only knew how hard it is to get a public-private Slack channel from the government.
It's really hard.
It's stories for another time. But we have a Slack channel that you get in. There's work groups in there that are online and asynchronous. So it is your chance to really move fast and test things out. And if we launch on March 31st with some of this and it doesn't work, then on April 1st, we'll decide how to change it. And you know, the rest of technology moves in that way. We don't do 10-year projects anymore. We do cycles and sprints and adapt as we go. And that's what I think healthcare needs. And I think that's how we get the older players to come along with us. Great. And if they can't keep up, then they can't keep up.
Yeah, and just a little bit, and adding on to that plug, I think, you know, getting more health systems and providers and also payers really deeply involved, and states. There's now an ability for states to be involved. You know, Amy is asking for, you know, truly the people who do this work to come together and demonstrate that we can actually, you know, achieve all those goals, make data move, and then ultimately be able to unlock more of those AI-first solutions that need that connected data.
And I will also say, like your example about Waymo, I came here a couple weeks ago for JP Morgan and got my first Waymo experience. And I also rode on the robo-taxi, the Elon Musk version, and I thought it was very striking that Waymo built out their system by having cars drive around with no people in it for a while on very strict routes and learning their way. And then they added people in without a driver. But they can't take you everywhere. My brother lives in Danville, not far from here. I couldn't take a Waymo there. But I could take a robo-taxi, it can go anywhere, but they have a human still sitting in the seat there to intervene, and they're tracking all of the things, and they report issues that happen so that they can learn from it. And it struck me that healthcare is the same. Like, there are certain things today, we're ready for the Waymo way. Mm-hmm. Do it without a human in the loop. You know, like a refill that someone's been on the same med forever. You can ask a few questions, look at their labs if needed, or home blood pressure or something. Refill. It's going to happen 95% of the time anyway. It's a great use for without a human. Great. But the robotaxi, when you get to maybe a complex cancer diagnosis that needs a lot of input, AI should be informing, but the human should be able to say, whoa, 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 like, let's do something different. And I think that's a good model for us to take, that we should be advancing on both tracks at the same time.
Yeah. I mean, it's a really tricky problem for healthcare because I think for the foreseeable future, a lot of what we do, the AI will be good enough to be useful, but not perfect. And so the human in the loop is the obvious model. Humans are not very good at that role, at being hyper-vigilant with a technology that they've learned to generally trust. And they will de-skill. And there's early evidence coming out about how quickly we de-skill. It's actually a little shocking. And so I think we're going to have to be very thoughtful about how do you build these dyads. And don't just say we have a human in a loop and it's all good, because the human's going to be the final sign-off, because over time that becomes pro forma.
Yeah. So before we talk more about that kind of framework for autonomous healthcare and what that looks like and how it connects to CMS's work and what you're seeing, Abhinav, when you hear these kind of things, what do you think about, you know, opportunities for us to, you know, better serve our customers and our partners? There's a lot of big changes happening from the government side, and then also practically as health systems and others really adopt these tools.
I think my general view on this is that software and was generally used in a way to basically enhance productivity of people. Now, one of the limitations of software, the way it was basically architected before, was the fact that it was rigid. And what that rigidity has effectively created for us over the last 20 years is the fact that a lot of things basically became regulatory, or basically payers wanting you to do something, and this is the only way it can be done, because the EHR or whatever software system you were sort of using is only allowing you to do it a particular way. Now, if you look at the largest basically indication of that, it is that that cost of basically administration in healthcare has risen twice faster than basically I think the cost of healthcare, or basically 4 times faster than inflation more broadly. So I think to a certain degree, what ended up sort of really happening was that the old architecture that we had on technology, which was rigid, did not have any flexibility to evolve, was basically I think a prime reason for a lot of capacity shortfall that we are seeing in healthcare. Things can be only done I think in this particular way, and because everything is structured in a particular rigid framework, this is the only way you could do it. In most estimates, we would sort of really hear that $1.5 trillion or close to that is being spent on administrative cost structure. If we were spending the same $1.5 trillion on healthcare, there is no shortage.
It'd be great.
Right? We would be able to serve our patients better. We would be able to live healthier lives as patients. All of those things that we really wanted, I think would happen if everyone is not spending a large amount of time just basically processing paperwork. And so, I think my biggest view, I think on AI and the way I sort of really think about the impact over the next few years is the fact that it will create certain degree of nimbleness on how we evolve. How do we think about software architectures? How do basically things effectively happen? 2022, basically, we are talking about 2.5, 3 years, basically, right? The amount of change in each one of our lives on how we interact with technology is massive. And I think that is going to happen in healthcare. We are all underestimating, I think at this point, the kind of impact on user interface and processes that AI is basically I think going to have. And yes, I think the EHRs are going to be important, but there is going to be a very fast-paced evolution of how the user interface between the provider, the nursing staff, the admin staff, versus what is on the other side from an intelligence perspective happens. So that is basically coming, and I think I agree that data is basically going to play an incredibly important role, whether Waymo succeeds, whether Tesla succeeds, whether anyone who is basically doing robotaxi effectively succeeds. The key thing, the model was not the limitation, the hardware was not the limitation. The limitation for a lot of companies that are wanting to do AI was enough data to effectively solve these problems. And if you are basically I think going to get to real outcomes, I think the difference between people who win versus not is going to be who knew basically their data infrastructures well, who curated I think this information so that the processes that they are wanting to create can be done using AI in a much more meaningful sort of way. And our view is that for a $5 billion net patient revenue health system, if you did this well, you could probably take $500 to $600 million of I think cost and reinvest into care. I don't think it's going to happen tomorrow. I don't think it's going to happen in 3 months from today, but that is the opportunity that effectively sits there. 10 to 15% I think of cost structure for a large health system or a large payer that goes into administrative costs can be redeployed to care, thinking about how do we think about chronic care management better, how do we think about remote patient monitoring better, how do we think about obesity better. A lot of those things are now in the realm of possibility. So that's I think my general optimistic, like I think, like view on where things are effectively going, that the guardrails that we've put on healthcare has made it like the most expensive healthcare system in the world. Probably not the best though. And I think like the opportunity for us like over the next 5 years is the fact that hopefully this is affordable and accessible to a lot more people, and we are going to be able to sort of really deliver the kind of care that everyone deserves per se.
Yeah, Amy, your reaction?
I was just going to say, I think patients are also starting to demand this so much that that's going to be the avalanche that pushes this over. I'd heard a stat recently that OpenAI said there are 200 million people on their platform doing health searches a week. And that number is just growing by time. And I wanted to share one example from my daughter's use of AI. So she's been trying to get into a CAR T trial. She's been on 21 meds a day, 2 infusions a month for 15 years. And so she was so excited about this CAR T trial because it could take away all of her meds. So she went into the trial. They declined her because she has ulcerative colitis overlap. They said that there was too much risk of taking her off all of her meds. She could have a bad reaction with her UC. So she was frustrated. She has me as her mother, so she actually has all of her medical records. And she loaded them all into ChatGPT. And she said, I'm tired of this. Find me another clinical trial. I'm over this. Find me something. And ChatGPT said, actually, I think you're eligible for that trial because I don't think you have ulcerative colitis. I think you have a slight deviation called microscopic lymphocytic colitis, which is a much slower reacting form of colitis and is not an exclusion for the trial. So it had read her biopsies from 15 years before. And when she brought it up, I kind of remembered we'd had this conversation of like exactly what kind of colitis it was, but it didn't impact her treatment. She was going to get the same treatment regardless. But it does make her eligible for this trial. And it also found in her records that when she'd had her tonsils out when we were going through our 1 and 3 month journey, that she had in her biopsy from her tonsils, it said evaluate for autoimmune disease, which no one had ever seen and was completely missed through her process.
Wow.
And so there are tons of things that AI is just good at finding and finding the patterns that humans are not. But once you put that kind of power into a consumer's hands, it's a totally different world. And I think providers that adapt to this world are going to be the ones that do well and survive, and ones that resist it and try to push back on patients using it are the ones that are going to miss out on this phenomenon. And I'll give you one other kind of funny thing before I hand it over is I've been in this crazy stressful job for the last year. I was doing really great with exercise before I started, and I completely fell off the bandwagon. So I went for my physical, and they were asking me how much I exercise, and I had to be honest. And they were like, you should just schedule it on your calendar, like find breaks to do this. And I went home, I was like, how am I going to do this? So I asked AI. I'm like, I'm really stressed out. I have this crazy job. I haven't been able to exercise. And you know what it told me to do? It said for the next week, just put on your exercise clothes. You don't have to work out, just put them on, and then next week come back and we'll come up with another plan. And of course, once you actually get your exercise clothes on, I went for a walk because it was like easy enough to go, but it didn't try to create some whole plan or get me to schedule something. It got me to do something very accomplishable, and it related to me. It understood me enough to that's what I needed at the time. So I think these things are going to revolutionize it. We need to embrace it.
Yeah. Bob?
Yeah, let me throw in a little doctorly cautionary note here.
I knew this was coming.
First of all, I think that's all terrific, and it's the Moby Dick problem. It was able to find stuff in the record that nobody has the time to possibly plow through.
Right.
I remember several years ago, I saw a patient who had a history of a pulmonary embolism, was on a blood thinner, and that's a pretty consequential diagnosis. You have to be on a blood thinner for your entire life. And I said, that's funny, no risk factors for pulmonary embolism, no prolonged immobilization. I wonder where that came from. And I happen to have a few minutes, and I flipped through the chart and found that this maybe 3 or 4 years earlier, patient had a physical exam, which we often abbreviate PE. And the next provider came and said, oh, PE, and pulmonary embolism became a problem in the problem list. So the fact that it plowed through the record and found stuff that nobody had unearthed is wonderful, and I think is one of the great use cases. One of the things that, though, has struck me is the use of these tools by professionals, and I put you in the realm of professionals as a nurse, is vastly different than the use of the tools by lay people who are non-experts. And right now, I can put stuff in a tool and say, I have an 82-year-old patient with a history of CLL who comes in with a fever, a white count, a creatinine of 3.7, an infiltrate on his chest X-ray. What do you think is going on? A patient couldn't do that. Doesn't really have the knowledge to pull all that together. It can give me answers that sometimes I would say, that's great, I'm glad I didn't think of that. And sometimes I say, that's just craziness, I'm going to ignore that. Non-experts don't have the ability to do that. And so I actually, and I learned this quite acutely. Jeff Fowler, who's the who's the tech reporter for the Washington Post, gave me a bunch of GPT answers to health-related queries a couple of months ago, and asked me to rate them basically. And some of them were fantastic and were better than I would have said. And some of them were awful and actually dangerous, and one was really scary, dangerous, basically telling a patient that you should use worm medicine instead of chemotherapy for testicular cancer, which is the most treatable and curable of cancers. And then Jeff just had a piece in the Washington Post yesterday where he took his 10 years of his Apple health data and put it in and saying, GPT, can you tell me how is my health? And it said, I'm giving you, your health is, give you a grade of F. And he said, what do you mean F? I'm a pretty healthy middle-aged guy and I exercise and my weight's okay and all that kind of stuff. And then he put it in the same data and it gave him a B. And then he put it into Claude and it gave him an A minus.
Right.
I think these tools are not yet truly ready. Now, as I say, I'm not ready for prime time. I think patients using them are terrific. I think they should. I think, as I used in the New York Times article, I said, the Biden's all quote, don't compare me to the almighty, compare me to the alternative.
Right.
And so some of the time, what you get out of these tools is going to be better than what you have now, which is try to find a primary care doctor in San Francisco or a psychiatrist or whatever.
Can't do it.
You can't do it. So the tools are useful, are beneficial in many ways, but I think the ultimate patient-facing tool is going to be more patient-specific than a generic GPT or generic open evidence.
Yeah.
It's going to guide the patient through. You're going to say something. It's
And
going to read your
hopefully
past
connect
record,
back to
connect back to your record and you
record.
and
Yeah.
give and say here's
Yes.
another question I have for you. The same way a physician would.
Yeah.
I don't think they're quite there yet.
Well, and that's exactly why we're doing this health tech ecosystem push, because if you can get your data as a patient, then you have all your medical records and you don't have to remember all of those things that you feed the model. So, in my daughter's example, the only reason it was able to do that is because it had her medical records.
Sure.
So that's why we're doing this big push for interoperability to help patients get their data in the app they choose so that they can use it on top of that. I also think that today is the dumbest these models will ever be. So they will continue to get better over time. And I think they should definitely be used in conjunction with a provider today. I mean, there's not really much option. You can't get ChatGPT to write you orders or prescriptions today. At some point, that will probably happen.
Probably.
But right now, you still have to go through a provider to do that. So I think it's more to educate the patient and help them through that situation.
We're seeing the building blocks of that, right? Like we've been talking about at the conference, right? We talked about we don't go straight to Waymo. We've had, decades of development along the way and pieces there. Well, we have the first pilot where, AI is doing a refill of a prescription. It's a very narrow pilot. There are a lot of guardrails, but that is a building block. That is a building block towards, a future delivery system that's transformed, fully by AI.
And I think it's great. I think it's terrific.
Yeah, I think it's great. I think you guys are seeing, you're talking about, you're teasing out the guardrails of this autonomous system, right? We don't have a solution right now, but we're talking about how this is actually playing out in real life.
Yeah,
How
and I
those
worry
guardrails-
more, and I think that I worry that we need regulation in certain parts of this, but I think for now, I actually am quite comfortable with a relatively hands-off approach because the innovation is happening so quickly. I don't think there's a way for the government to keep up and the government to be a facilitator here. Feels like the right call, but I do think we have to watch patient-facing uses of these tools very carefully because, again, yes, it had all of the information about your daughter's case, and that's terrific, but the ability to take the output and say, oh, that's reasonable, because there are other outputs it's going to give you sometimes that are just going to be wrong. And I think you would know that, but the average patient might not.
Yes, and I feel like we're hitting into a pros and cons side. I'm much more in the middle in this,
Me
but
too,
I'm playing
so.
a little devil's advocate. But at the same time, my daughter's gone to multiple doctors and gotten 3 different opinions from 3 different doctors, and
Yeah.
they can't all be right. So I think there's balances to this, and I do think we are trying to provide a lot of safety and privacy as part of this as well. So one of the requirements for the apps to be in our app library that we're putting on Medicare as part of this and through our health tech ecosystem is that they have to be certified by the Care and Code of Conduct or the DIME seal of approval, which basically says they'll treat the data like you're a HIPAA covered entity, even if you're not. You won't do marketing to the patient. You'll explain what you're going to do with their data in plain language, not some long scrollable terms of use or data use agreement. And then the models like ChatGPT and all those that joined our pledge also agreed to put them in a private area and not to train the models with it. So I think there are a lot of things here. And from a regulatory standpoint, I think the biggest thing is we need to put clarity around regulation. We need light touch regulation that allows innovation to happen. And we need to discourage as much every state coming up with their own regulations because that just stifles innovation.
She says in California. But I think it's interesting that both of you are actually coming to kind of the same place around this is moving too quickly for us to have, really hard regulatory rails, and it's actually pushing the limits of our existing legal frameworks like HIPAA. And so we have to figure out what can we do right now to keep those things moving forward while also, providing some of those guardrails and teasing it out both at the federal level, potentially at the state level, but also every health system has their own, governance committee around this work as well.
Yeah, and we're all very conservative, and I mean, in some ways that there are guardrails in the system. The malpractice system is a guardrail. The conservatism of legacy healthcare organizations are pretty strong guardrails. The privacy, to get
Can an
anything
AI algorithm
approved.
be sued for malpractice?
What's that?
Can an AI algorithm be
Eventually,
sued for malpractice?
yeah, eventually that's absolutely going to happen. I mean, all the companies, of course, are going to say that we're not practicing medicine. The doctor was the final person who signed it. But as we move more toward autonomy, as you know, the company that got the Utah contract to do the prescription refills bought malpractice coverage for that, and I think that's just the start. And I actually think it is just the start. There's going to be more and more. If you look at the primary care system in the United States, it is so fundamentally broken that we have to move toward the ability of patients to get autonomous care of their cholesterol or of their blood pressure or to get their vaccinations or whatever it is. And the idea that a doctor is always going to have to sign off on everything and the AI won't be able to prescribe Lipitor is just stupid. Right. But if that's the case and there's no human in the loop, then it's going to have malpractice insurance.
Exactly.
What I wanted to say too, I think part of our job is to also start to incentivize some of this. So I don't know if everybody's seen the access model that came out recently, but that's kind of CMS's first step into providing incentives for technology-enabled care. So based on the ecosystem, we knew we needed incentives to also drive behavior. We'll get brave companies like Innovator to start in the beginning, but not everyone will. So the access model takes these apps that are in our health tech ecosystem that work with patients directly, and it can pay them for outcomes. So tech, like an app, can become a Medicare Part B provider, which means they will also have malpractice insurance to that conversation. And then they can take on the care, like four different tracks: cardiometabolic, both early and later, musculoskeletal, and then anxiety and depression for behavioral health. And so if you manage that patient through and get the outcome desired, then you get paid as a Medicare provider. It also does involve the traditional provider either in recruiting patients to do that. They can get paid a $10 fee to onboard people into that because they're going to have conversations around it or someone on their staff. But then they get paid 3 times a year for reviewing the care plan as it comes along as well to keep them in the loop. Providers can also be the ones that do the whole thing. They can provide the app and the piece, but they can also partner with vendors or just their patients may fall into it without being recruited by their provider. But it's a great way to start into this to get incentives to pay. The other one is the Rural Health Transformation Fund, which just is awarded $50 billion out to the states to modernize rural health. And so when we were talking about access earlier, that a lot of times in rural health, something like these tools may be your best bet to get care where you don't have a lot of access, or even in urban areas on the weekend or when it's hard to get care. And so we're really incentivizing the states to invest in this technology, both interoperability and patient tools like this.
Yeah, that's great. And we've been talking about these kind of fundamental shifts, rural health transformation, the new models that are paying on outcomes. We actually were lucky enough to have Amy join us at our JPM event where we talked about should AI vendors bear the risk on outcomes, and that was a pretty interesting discussion as well. We're hearing a lot from folks about how they can be involved in these things. Anything else you want to add, Abhinav, on the framing around this?
I think it was pretty comprehensive. But I really feel I think this is also a push towards value-based care succeeding. We've had value-based care I think for a period of time, and one of the primary barriers for value-based care has been that we don't have enough people to basically carry out all of the care management, all of the processes that are needed for value-based care to truly succeed and navigation to happen.
But they're good things for they're good things for every population, every group of people, regardless of contract. So how can we actually do more of that?
Yeah, and I just think I think as this group effectively thinks, because this is I think a lot of you are basically thinking about the future of value-based care and how do you sort of really think about investments in those areas. If basically AI succeeds in the things that we are sort of really I think all saying that it will, it is such a massive unlock for providers to be successful in value-based care paradigms. If you basically take fully capitated models, and if you are able to understand which patients and what are care pathways and how do you sort of really I think treat them, and AI basically starts to act as a force multiplier in that way, the likelihood of success in a value-based care model effectively increases multifold. So I also sort of rethink I think the team I think model fully capitated I think risk models, or basically rural health transformation, or the access models are all stepping stones towards a fully integrated, I am going to take care of you healthcare model, rather than a traditional I think fee-for-service I think model. So that would be I think one thing that I would just say, that the payment model effectively merging towards value, and the technology now reaching I think a point where you could do a lot of these things is just such a large opportunity for any health system who is thinking about their future economics and what does it sort of really look like. And value-based care, in my view, I think is going to be far more consequential to the P&L of a health system going forward than it was I think the last 5-10 years per se.
It's also going to be the pricing model is going to be really challenging under fee-for-service.
Yes.
If you've got to get paid, think about if you bought a car and there's an extra charge for your AI-enabled steering wheel and your AI-enabled mirror and your AI-enabled radio, and it just doesn't make, at some point, the model has to be, here's a fixed price to do this thing, and if you, provider, believes that using AI to do these things as opposed to alternatives is a better way of doing it, then you will do it and you'll do well financially. I think this may be the thing that finally moves value-based care from being around the corner for the past 20 years into something that's here.
Well, we don't see a financial model that will allow us to meet the moment of massive cuts necessarily, right? Challenges of rural health transformation moving forward, that is not going to be centered in this autonomous healthcare future, so to speak. We don't, like you said, we don't have enough people. We can't afford to continue to grow in that way. We can't afford to keep spending so much money on administrative waste. We are increasingly having the imperfect but very much real here tools to do this. So this has to be part of what moves that forward. So we're coming a little short on time, but I would like you to kind of give, let's say you have an audience here of health systems, payers, folks in public sector. What should they be focusing on now? Time is short, right? We're almost at the end of January 2026. It's happening really fast. Lots of things coming forward in the ecosystem. What should they be focusing on now for the rest of the year to be part of this future?
Yeah, so just at a high level, I think most people have seen that this administration really wants to hear from people. So I think come join our ecosystem, respond to RFIs. If you have ideas, come let us know. First of all, we really want to hear from people. We're trying to drive change as fast as we can. We know we have a limited time to do it. I think you need to invest in infrastructure and making sure that you have the ability to get the data and to share the data out there. I think the time has come that it's just not going to work anymore to not share data, and you're not going to be able to do all these things we're talking about if you aren't getting external data as well. So we have to make it work for everyone, and so I would invest heavily in infrastructure and data. I think we also can't think of AI as like a layering on of things, just like you were talking about in pricing. It has to be foundational in everything we do going forward. And so I think you need to not just have like a department that's doing AI or a chief AI officer, but you need to have champions across your whole organization that are going to think about that every day and drive it and bring it lower into the organization so that it's part of everyone's view.
Yeah, definitely. Bob, any final thoughts for the audience here generally?
Yeah, I think part of the job of leadership is to convince folks that this is exciting, that it's net positive. They hear you say that, and there's still a little, bird on their shoulder saying, "Is this going to take my job?" So you've got to figure out how to navigate that. I think what we typically say, and this may be happy talk, and it might be real, I'm not sure, is that we are planning to grow the health system a tremendous amount. And we would normally be hiring a bazillion additional billing people and this people and that people, and we don't think we'll need to hire as many as we did, as opposed to many of you are going to lose your jobs. But I think that's just going to be an incredibly important thing to navigate. I think in some ways a good piece of news politically is I don't believe many and maybe even any physicians or nurses are going to lose their job in the foreseeable future. The unmet needs are so great that even if these tools increase productivity by 20 or 30%, they just get us to a place where we can sort of meet the unmet needs. But I do think you look in the billing department and the quality department and the call center, there will be job losses, and I think leadership is somehow navigating that, trying to reassure people to the degree you can, but trying to also be authentic about what's going to happen. People need to learn how to use these tools. People, can't just put their head in the sand because this is real. I often use the Hemingway quote when one of the characters, and his son also rises with going bankrupt. Another character said, "How does a man go bankrupt?" And his answer was 2 ways: gradually and then suddenly.
And then all at once.
So this is our Hemingway moment. This is going to happen not all at once like 3 months, but not 10 years. This is a 1 to 3 year time horizon with massive transformation. And I think you're not being a good leader or steward if you're not getting your organization ready for it.
Yeah, that's exactly right. So just a few things in reaction to what you said. On the interoperability side, we do have some friends and partners in the room as well have been working on this. So most folks know that we work with Metroport. They're here as well. Our friend Kristen from Be Well, who are working with OpenAI on that pilot, is also in the room, also part of the CMS Health Tech ecosystem. Also, we have our interoperability leaders here, Dave Castle's around. So if you have questions about that front and how you can work with Innovaccer on the ecosystem, please contact us as well. And then on everything you were saying, it aligns with what we've been talking about here and showing with our pilots and quick time to value and showing the real numbers behind things like automating prior authorizations. So we have at least an interim solution to move us forward here. So if you haven't already, please do scan that QR code and sign up for a pilot, and we'll show you what it really looks like. That's how we think we're going to go from right now to the next 6 months to the rest of 2026, showing you how you can immediately move these things forward. Yep. And I'll let Abhinav say potentially a final word here.
And I think the one thing that I would just sort of really say, any adoption of net new technology has been hard, like in any other cycle. I think whether that was computers starting to come, whether that was internet starting to happen, whether that was mobility starting to sort of really happen. One of the risks that I think every organization effectively runs, and we are sort of really thinking about this internally at Innovaccer as we are building things, is that there can be massive fragmentation that sort of really happens because you end up using 20 things for 20 things, and not having a little bit of a infrastructure to connect things. Last 10 years, 15 years, we've been trying to solve EHR interoperability. And if the next 20 years we were to solve agentic interoperability, that would not really be a great place to land in general. So I think just thinking about these things, because this is an opportunity where a net new technology is starting to appear on the horizon. And how do you sort of really think of this systemically? How do you redefine the entire operating model, entire structure is an opportunity that exist here and now, and setting the right infrastructure and guardrails into place, in how this is going to evolve. This is the year, these are the couple of years where you could sort of really do this right, versus basically having something does my prior auth, something does my contact center, something does my interop and coding and all of those things. That is a nightmare that you don't want to basically like I think like get into. So I think like that would be one piece of thinking that we have basically been doing like at Innovacer internally as we are sort of really thinking about things. But I would say like the AI push is going to be an inevitability right now. Everyone is going to have it and use it. And how do you sort of really react to it, and how do you set up like the right kind of infrastructure in place is just going to be an incredibly important thing as you think about adoption of AI more meaningfully.
That's great. Well, please join me in thanking our incredible panel. Thank you for making the trek. Thank you so much.